tremendous amount of information about transverse myelitis since Dr. Kerr began the center here in 1999. And Chitra has been a part of that information collection and analysis process almost from the very beginning. Chitra is going to spend the next half hour answering your questions about what have they seen and what have they learned. So this is a great opportunity for you to talk to Chitra about some of what they understand now about the variability of the patient population that they're now learning about in transverse myelitis.
I was honored to be here this week with some of these wonderful doctors. I'll be 10 years post transverse myelitis in November, and yet some of these wonderful doctors and the ones at Kennedy Krieger are still working with me on symptom management and how can I get better even though my attack was almost 10 years ago. Can you guys address something, because that gives us all a whole lot of hope?
So you had transverse myelitis some time ago, and you stabilized at a certain point, and now 10 years, 8 years, 13 years later, something else happens. How do we think about that, and is there something we can do? So the answer is yes. So I saw Julianne for the first time, and we decided together that there's lots we can do. And it depends upon a lot of things. It depends, I guess the first question we ask is this recurrent disease? And it is not unheard of for transverse myelitis to come back in a mild form that's very difficult to detect at some time after the initial onset. Now we try to do a good job at the acute onset of knowing that, but sometimes we don't. So that's the first thing. You've heard about all of these cousins of transverse myelitis, and so we need to look at that. Is there some ongoing inflammation? Is there some other, is this part of MS, or is there a rheumatologic disorder that's come up? For example, Sjogren's syndrome, right? They're all autoimmune diseases. They can run together. So if somebody has a worsening after the acute onset, that's one of the things we think about. What's the other one we think about? If somebody acutely gets worse long after being stable, is an infection, right? So any kind of infection, even one that you might not notice, will cause worsening of symptoms, spasticity, pain, decreased bowel or bladder function. We think about other issues such as nutrition, because for most people who haven't had one of these disorders, that's not necessary for you to function optimally. People eat Cheetos all the time and go about and do great things. But for people who've had transverse myelitis or MS, it becomes more important what you eat, nutritional status, those types of things. We think about physical therapy because most people who haven't had transverse myelitis don't need to do stretching and exercises on a regular basis to maintain their function, but people who have had transverse myelitis have to. And so we look at that regimen and we see if there are things that we can do that can help. Jim Boner, you want to come up here and you can help us with these questions as we go? I didn't see you out there. Do you guys have comments?
Frank is out there too.
Where's Frank? Frank? Oh, Frank, this one's specifically for you. Come on. So Frank, what do you think about a child who comes in who's had some kind of a worsening after the acute onset sometime thereafter?
Thanks, Doug. Is that all I get, just the child's worse? I didn't hear the question, but I think that what I heard part of Doug's answer was I would think about overall conditioning and probably some other things too. You'd probably want to know something about how he's getting along in school and whether there's some things which would impact how he's doing in terms of his relationships with his peer group and classmates. Now, I don't know what the context is. This is sort of, I'm getting the question blind, but And then, of course, what we always do is we want to check them out in their braces and their mobility devices to see if they're the right size. Oftentimes, kids grow quickly, and no one realizes that the AFOs or the braces are now pinching their feet and causing a problem with pain or discomfort.
Everybody should be in tune with the possibility of depression, right? By now, you're all up on that. This is a big thing that happens with all autoimmune diseases. It's not failure to cope. It's not weakness. It's a chemical imbalance. The inflammation triggers a chemical imbalance. I know you've all heard that by now in here.
I'm sorry, Doug. And I think what Adam said the other day was really key, too, for pediatrics at least, is that it's not going to necessarily show up as a depressed mood or a sad child. They might have change in their weight. You know, they might have lost weight or gained weight. And I think irritability is a good sign, too.
Greg, you want to say something?
I just want to emphasize that those are some of the symptoms that occur in pediatrics, and kids of all ages. I mean, even kids who are small can get really, really depressed. So just because you think they're under 10 years of age doesn't necessarily mean they're not going to get depressed.
But I may have misunderstood the original question. I think part of it, though, was also if you're someone who's had an insult remotely and now you're looking to improve function and improve from where you are now versus a worsening state, there are a lot of things that can be done. And everything, has been said over and over in these sessions, is individual. Okay, so every patient is different. And I think what ends up happening 90+% of the time in the patient-physician and patient-therapist interaction is, in general, a lack of clear communication. And unfortunately, the American healthcare system is set up such that you get limited time with every encounter with each of these important members of your team. And everybody can't see Doug, everybody can't see Greg or Jim or somebody. We have to go back to our communities and see healthcare professionals who may not be the penultimate specialist in a certain field. So what do you do in those situations to get the advice to improve your functioning, to improve your situation? And I think the clear thing is, I liken it to Little League. You want to throw up as many softballs as you can for your healthcare professionals. You don't want to throw curveballs. You want to make it as easy for them to give you the advice that you need in a clear and concise manner. And one of the ways to do that is being very clear about what your goals are. And I think we see this missed in therapy most often. So if you're using a walker and you say, listen, I'm fatiguing. I can't go to my son's Little League game because to go from the car to the bleachers, that's it. I'm done. I have no more energy. And you want to improve upon that. Often what I'll see is patients sit down and they'll say, well, I'm not walking well. I'd like to walk better. That's a curveball. Okay, so that's saying to the therapist that they need to go through every possibility. Whereas if you say, listen, what I want to improve is I'm walking 100 meters, I'd really like to get 500 meters. Okay, is it my energy level? Is it my balance? Is it my strength? Help me to achieve this goal. I think your interaction with each individual therapist and each neurologist is going to be different. So for some patients, it's going to be aquatherapy. You might benefit from being in a pool 3 times a week. Get gravity out of the equation. Do more stretching, do more movement. For some people, it's going to be strengthening muscles that have been ignored, going back weeks, months later, and realizing, well, you've gotten the hips well, now you need to work on the knees. We ignored the knees, so you're still having problems walking. And understanding that the advice you get from your doctors and your therapists creates a moving target. So as we solve one issue, you may see something new pop up, and that's when you need to come back and be interactive and say, we've succeeded here and failed elsewhere, and try and get those individual changes. In terms of the general question of can you improve, the answer is absolutely yes, as long as you're setting reasonable goals. So if it's transfers, if it's length of walking, there are a lot of things that can be achieved either through medication or through therapy, but you have to be very clear with your practitioners in terms of what you're looking to get. More softballs, less curveballs.
Who's got another question?
I think the question was what do we do when patients have what we call pseudo exacerbations, where they're feeling worse, but it's in the setting of a cold or some other illness that's happened, and what do you do in that situation? I think the most important thing is to recognize it for what it is and treat the underlying cause. And oftentimes it's the patient that may have to tell the doc about this. If you see one of us, we'll be clued into it, but oftentimes you're seeing a primary care doc that's never even heard of transverse myelitis or a neurologist that's heard of it but barely seen it. So it's important for you to be a bit of a self-advocate and recognize that this is a possibility. When our patients come in worsened, we almost always send a urinalysis on them to make sure they don't have a bladder infection, because they often don't know when they've had a bladder infection. And we frequently do blood tests and things. So in addition to recognizing it, I think it's important to treat it. So if a person is worse, it's very important to treat fevers aggressively. This is straight physics, and if you heat up an electric wire, the resistance increases in that wire. And if the wires you're talking about are axons in the nervous system, you just won't get the signal through. It also makes it very hard for the nerve to send the signal to the next nerve across the synapse, and you get signal blocking. So it's important to recognize that and treat it with aspirin or Tylenol or whatever you use to aggressively get the temperature down. There are a few people that we can't figure out if it's the fact that they have a bladder infection or whether they're having a real exacerbation. And in those situations, it's important to treat both ways. So you can do that as well.
I have a question. How many people have tried to cool themselves down? If they feel that they're kind of getting worse or weak, have tried some way to cool themselves?
1, 2, 3.
Not that many.
3.
Yeah. I mean, does it work? Does anybody find that their symptoms are temperature dependent? That when they get hot, whether it's a hot shower or a bath or a hot day, that they get worse, and when they cool down again, they get better? Okay.
I find humidity to be worse than temperature.
More important than temperature?
Spending some time out with southern desert the last couple of years in 108 found I was able to do the functions so much better, although hydration being an issue, but than New York kind of humidity or Northeast.
Interesting. You know, so what Dr. Bowen talks about is, and he says this, pure physics, that your neurons conduct less well when they're hot than when they're cold. And that's not particularly relevant in somebody who's got fully myelinated axons, but it is relevant in somebody who's got a state of injury somewhere in their nervous system, and that's true to all the diseases we talk about. Now, some people notice it more acutely than others. In my experience, some people, it is a really dramatic thing. And so, for example, when you get maybe a low-grade urinary tract infection, you may not feel feverish. You may not have fevers that you know of, but your core body temperature will in all likelihood be up by 0.1 to 0.2 to 0.3 degrees. Not enough for you to know a thing about, but could be very significant in terms of functionality. So I tell people to cool themselves down, no matter however you do it. So it's one of the reasons I like water therapy. I don't like the really hot therapy pools. But if you get a nice pool that's, say, 82 degrees water, your body temperature is 95-ish, 97, somewhere in that, depending on the time of day. That will cool you down. It not only allows you to carry out therapy, but your core body temperature goes down. And a lot of people, in my experience, come out of that pool feeling better. But there are other strategies. So I tell people, you know, those blue ice packs, put them everywhere you can. Put them in your armpits, put them here. If you get hot, cool yourself down. And there is one of our colleagues, Elliot Froman, who has people swallow these thermometers. And so it really gets a core body temperature, right? And so he can measure it while the thermometer is inside. And he swears, you've heard him give this talk, Jim? He swears that there is a very big functional change even as you go through the day depending on your core body temperature. There are cooling vests now. There are these vests that you can buy which cool you down, and the effect is 0.2 to 0.3 degrees of core body temperature. You want to comment on that?
How about hot flashes?
I never had them.
I'll make one other comment about the cooling. We did a study that's not yet published, but we actually a couple of studies. One is that if you look at the peak exercise output of patients with demyelinating disease, while they're wearing a cooling jacket, they can exercise much heavier than they can if they're not wearing the cooling jacket. So it helps with peak performance. The other thing is we did kind of an odd study where we took patients, and you can cool them for about an hour before they start getting chills to try to warm themselves up. And we did before and after hormone levels, and basically none of them are changed except norepinephrine, which nearly doubles. So in addition to the cooling effects, it's almost like dropping an ice cube down someone's back and kind of goosing them a bit. The norepinephrine is an output of your autonomic nervous system, so it just revs up your whole system. So some people feel better just from the cooling of their skin in that way.
Comment in the back?
Dr. Kerr, you mentioned the importance of nutrition. Has your department published any nutritional guidelines for disease?
We have not published guidelines on this. I really think that these guidelines wouldn't be necessarily unique to transverse myelitis, but rather general in terms of immobility or decreased mobility. And so things like calcium and vitamin D and those types of things, to me, are out there, and I recommend them to my patients, but we haven't published anything specifically on that. You guys want to say anything on that?
What about B complex?
B complex.
So I think this holds true for most of the vitamins. The first one is if you're taking in a healthy, regular, balanced diet, you should be getting all the vitamins that are necessary. Taking supplemental vitamin C, vitamin E, and most Bs are generally thought to be safe. There are some you definitely have to be careful about. So you can overdose on vitamins. So we have had patients, and I don't know if you guys have had this experience, come in a wheelchair from vitamin B6 overdose. It is neurotoxic in excess levels. And so it is definitely all vitamins are not safe. So just because 100% of the recommended daily allowance is good, 1,000% is not always better. Okay, so sticking to those general guidelines, taking a multivitamin a day, there are some that we know are absolutely safe. So the calcium, the vitamin D, vitamin E, vitamin C, I don't know of any data to say that excessive calcium. Making sure a daily calcium supplement, though, is probably perfectly acceptable and not a problem. But what we see is you have to read the labels. So you've got your once a day, your B complex, your multi, and when you read the labels, all of them, I'll use the example, have B6 in it. Okay, so you're doubling or tripling up. So that's why maybe a once-a-day vitamin and then a supplemental calcium or vitamin D is probably plenty. I don't know if you...
How dangerous is sunlight, and how effective is sunblock?
I'll answer the second part first. So sunblock is effective in terms of preventing skin cancers and malignancies when used appropriately. And that means reapplication every 1 to 2 hours while in the sun. Every 1 to 2 hours you have to reapply. So when you talk to a dermatologist, it's less of an important of getting the SPF 500 versus an SPF 30 versus reapplying it on a regular basis. And it's quite effective in terms of changing or preventing skin changes. In terms of danger in the setting of inflammatory disease, I'm not sure there's great data. There are some hints from some of the demyelinating diseases about sun exposure and vitamin D activation, because in order to get vitamin D to work, you do need some sun exposure, but I don't know in terms of data saying that too much is toxic.
No, except some of the medicines that you're on may make your skin susceptible to sun.
You mentioned vitamin E, and do you think there's enough in the multivitamin? There's been some studies recently where extra E isn't too good for you, so I stopped the E on him.
I would not not be taking extra vitamin E. Vitamin E is a fat-soluble vitamin, and it accumulates. There was some evidence that it might be protective for heart attacks and strokes. That's not true. It puts you at a slightly increased risk. I would not take an extra E. True. Some people with lupus have to be very, very concerned about sun.
Back to the hot flashes, are they in the same family as, exerting yourself or eating? My doctor tends to want to increase my doses of, pain, to lower the pain or whatever. But I'm running sweat, but after that, just get the chills off.
Craig, you want to try? So when I think of hot flashes, obviously you think, especially in women, of hormonal issues or infection. But you also think about either an infectious problem or you think about a rheumatologic problem, because both of those cause hot flashes. Now, I wouldn't worry about necessarily kind of the very isolated, very quick hot flashes, which is a perception of warmth. It's not really necessarily an increasing your actual body temperature. And it's an alteration in autonomic nervous system output. So it's your autonomic nervous system is that which controls your heart rate and your blood vessels and things like that. There are medications for it. They're modestly effective, but you have to make sure the other things have been looked at first, infectious and rheumatologic.
How do you go about that, by blood test?
Right, by blood test. In the back.
In all of the patients you've seen here at Johns Hopkins, are there any clusters that you uncovered relative to geography?
Chitra will comment on that.
So we've seen some clusters we've heard of in Texas. Remember, we've seen a few cases that came. So there are a few clusters we've seen, but none that we have, none too large that.
Sandy, you want to comment on this?
You hear about it all
Is
the
anybody
time.
here from Michigan? So the first state of referral to Johns Hopkins is Maryland, not shockingly. The second is Pennsylvania, and the third is Michigan. Now, I don't know why. Maybe it's because everybody in Michigan is smart. I don't know. But I just wonder if there are localized clusters. Sandy, you would know this more than anybody.
Well, TMA did a survey, 815 respondents, and we looked at the states where people lived when they filled out the survey. We don't know where they came from, how long they lived there, and we looked at whether the distribution of transverse myelitis could be explained in any other way than population, the population of the state, and it couldn't. The largest numbers are from California. The smallest numbers are from Rhode Island and Utah. So it looks like, at least from what we have in our database, that 815 people, that their distribution is equal to the distribution of population across the country by state. Having said that, I have lots of anecdotal evidence, and I'm sure these folks have lots of anecdotal evidence about a small community in Australia where there's, a population. I think the Texas community you're talking about is like a population of 9,000 people, and they've had 4 or 5 cases there, or a small community in Australia where there's maybe 4 or 5 different cases. In fact, there was a newspaper article from the community that had a photograph of all of these people sitting at a picnic table, and it was a very, very small community in Australia. And they get in touch with me because they want Dr. Kirk coming out there to do the environmental analysis and their community. And I'm thinking, like, what is he going to begin to, does he start with the soil? Is he going to be looking in the ear? Where's he going to look? But there does seem to be some...
The bar. It's in the bar.
Looks like, sort of random distribution, but we know anecdotally that there seems to be some concentrations, and why, who knows?
Do you want to get back?
Yeah, I think if